We're working over here. All right. First of all, huge thank you, Jeff. And Kelly, who's somewhere in here, wherever she is, back here, and Ron, who's not here today, but it wouldn't be without these professors that I would be working in global health. So huge gratitude to all of you, and agreed to the institution, because it's an institution like this one who embraces liberal arts education, where you can actually pursue paths like global health that did not exist as a minor when I was here 15, 20 years ago. So I really appreciate being back here with you all. We're going to talk today about global health and the equity imperative. But before we get started, just so I have a sense of who you are, could I get folks who are either a peace studies major or minor to just raise your hand so I can kind of get that sense? Okay, all right. And then for folks who are global health minor or global health minor aspirational, I know this is new. Okay, and then everyone else is none of the above. What are you if you're not these things? I'm curious. What is? Yeah, go for it.
Secondary ed teacher.
Secondary ed, awesome. I'm going to repeat things just for the recording. Others? Communications, biology, right? Okay, that one. Yep, got it. All right, okay. This is just helpful for me to understand where you're coming from, and hopefully we have something exciting for everyone today. So this will be a talk in 3 parts. So we'll do a little bit of the intersections between peace studies and global health, or peace and global health. Then I'll walk you through 4 exciting innovations I think are cool in public health or in global health, and just kind of whet your appetite about what's out there. And then we'll talk about the way in which global health innovations are evolving in terms of the innovations themselves, how they're funded, the role of equity and partnership equity in those. So before I dive in too much further, and I'm glad that Jeff, you sort of set the pace for this, I do want to make an important note about language, and that is that the language I'll use today to sort of characterize the places in which a lot of these innovations are designed for, designed in, applicable to, is really, the language is really imperfect and insufficient, right? So there are a lot of terminology that get thrown around in the development space around third world, which is really inappropriate, developing or developed world, low or high resource, and often these characterize things in really sort of demeaning ways. And so I'm going to use low and middle income countries mostly, unless I can use something more specific. So, but it again is imperfect. And so I just wanted to make that note. There's a really excellent article that came out earlier this year about the language we use to characterize countries in the development space. And I have it linked here. There's also a link to the slides at the end. So if you don't catch it now, you can catch it later. Okay, so part 1, the intersections of peace and global health. So let's start by, what is peace? Anyone want to give a bold definition for what is peace so that we can kind of think about how these 2 things intersect? What is peace? Shout out, what comes to mind? Anyone? Not war, what is it?
Harmonious interaction amongst people and environments to create a better future.
Okay, harmonious interaction against people and environments to create a better future. Excellent. Other ideas? I mean, yes, that is definitely peace. What are other ways you think about peace? How do you sort of kind of characterize it in your head? What comes to mind? Anyone? Not war, maybe, right? That seems antithetical to peace.
Lack of conflict.
Lack of conflict, thank you, that was perfect. Anything else? Okay, we're gonna do a quick teaching then, and we're gonna make you all peace studies experts, although please still consider the minor or the major. So one of the seminal concepts of peace studies is this one from scholar Johan Galtung. I always say his name wrong, but Jeff is nodding, so I think I did it right. He's Scandinavian, and I should know, since I'm Scandinavian, how to do that. But essentially, it starts by understanding violence before you can understand truly what peace encompasses, right? So if you think about violence, then it comes in 2 ways. It comes in direct or personal. So this is that self-harm, or not self-harm, sorry, the harm of another. It's war, it's violence in that kind of visual way that we see in the news. It's someone being, victimized by an assailant in a physical way. There's also then structural violence, which is that indirect violence, right? And this is the idea that there is preventable suffering being had through systems and structures that enable or even facilitate such suffering. So if you think about violence in these 2 ways, which I think we can probably appreciate is accurate, that there are multiple forms of violence, then you can actually think about peace as also having a few different permutations as well, right? So there is, of course, the more traditional and absence of personal violence. So when there's not war, there's peace, that thinking of what's right at the surface when you think about peace, the absence of personal violence. But then there's also an absence of structural violence, which you can also think about as the presence of social justice. So if there is not this structural violence, there is a presence of social justice, which is a positive thing, and therefore you have negative and positive peace. Okay, so when you're thinking about peace and you're sort of internalizing what really is peace and why do people study it, or what are they even studying, you can think about it in very simple ways, and of course Kelly and Jeff probably have a few more pieces they would add to this, but you can think of it as having both negative and positive peace. And so, of course there are then ways to think about, well, what are you really studying or working towards when it's peace? Maybe not only the negative peace, but also how do you create systems that facilitate this positive peace as well. So now that you're all peace studies experts, right? Okay, we're going to move on to global health. So this is the field of study and research and practice that really puts an emphasis on global health equity. How do we achieve health for all? And as Jeff, I think, also indicated a bit in the introduction, this is something we really need. And that's because there is a long path to health equity still ahead of us. So this is a burden of disease map. So essentially what you're seeing is that areas of deeper red are indicating a high concentration of disease burden, which is currently shown here in disability-adjusted life years. This is a concept in health and in demographics, but essentially that there are premature death or life with disability that exist, and you can actually count those premature deaths and life with disability, unnecessary disability, in terms of 100,000 of the population. So in Central Africa there, you're seeing high disability-adjusted life years, or a high concentration of really unnecessary suffering is maybe the simple way to characterize this. So we have not achieved health equity, right? And I'm sure you all recognize that. Ooh, sorry. So the other thing you want to think about when you're thinking about the need for global health is, of course, what I think both the provost and Jeff mentioned, which is that we also live in an era of pandemics, of outbreaks, of things that transcend borders, right? There's no health that doesn't exist without care for our neighbors, whether that's our true neighbors next door, but also our neighbors in other countries, on other continents, because all of these infectious diseases are also, of course, traveling, and it also affects our health here at home. So a lot of reasons or justification for why global health is out there. And then, so glad you brought up Paul Farmer. This is probably why I got into global health. Dr. Farmer was an incredible advocate for health equity. And I just love this quote that also sort of characterizes this need for global health and really gets us into this mind of equity. This is actually not him. This is in the foreword of his book, but it so nicely characterizes the book, Pathologies of Power. But it's this idea that we live in an age of science, technology, and economic affluence when we can, for the first time in history, deal with the diseases that ravage humanity. And yet, all of that is beyond the reach of our depraved masses. And that's where the pathologies of power are taking their toll. So, you can think about, well, what does it mean to live in an era where we have all the solutions or we have most of the solutions to our disease problems, but aren't applying them in ways that actually kind of equalize our health access and our outcomes around the world. Great, anything you can read of Paul Farmer, highly recommend. He's an incredible inspiration. Okay, so now I'm going to turn to you all a little bit before we move on to our next section. So I did a super brief, what is peace, what is global health, and some thinking about how equity appears in global health, right? So what are some of the intersections or kind of connections that you're seeing or that you're conceptualizing between these two topics? Anyone? Brave? I'm just gonna sit silently. Is there a connection? Yeah, we got someone back here.
Well, if we're talking about structures causing violence.
Structures causing violence, yep.
And our healthcare system is a structured
Yep.
system that's been set up, and it's being insufficient to give people healthcare, that is a form of violence.
Yeah. Great, yeah, so just for the recording, so this idea that if healthcare is set up in structures and those structures are insufficiently meeting the population's needs, then there is some inequity being delivered through structures, right? And that's structural violence. Absolutely, that's perfect. Anyone else? Any sort of things that come to mind? Any connections that you're seeing in these concepts? Anyone? Okay, I'll offer up how one sort of mental model that I think of how these two are connected. Oh yeah, you're taking a photo. I thought you were going to the mic. So this is a really simple way to look at the mental model, but for me, I think similar to what this student said in the back, in my mental model, I look at it as global health is contributing to that positive piece, or piece as a whole, because it is attempting to correct injustice in health. So if we think about that positive and negative piece, and we particularly hone in on the positive piece element, what we're building is a world that's more equitable. We're building fair access for people. We're trying to correct systems that otherwise would feed inequity, right? We want to correct all that. And so this is one way to look at it, but I actually think there are a few other models I could have illustrated. I think there's some more simple things. Global health can address health issues that appear because of direct violence, right? Certainly there are parts of public health that address, the health impacts of war or refugee health, or a lot of things that are really directly related to the direct violence piece. There's also probably a sequential or logical way to look at this and in order. But yeah, this is maybe just one way to look at it. Okay, yeah, go for it, please. One can't be without the other, yeah.
Because peace, like global health and health in
Yeah.
general, kind of trickles into peace in general. Because
Yeah.
if you have to leave one country to another to seek safety and
Yeah.
then within that, like, to access health.
Yes, it's a great point, right? So if you have to leave one country for another due to violence and you need to seek health elsewhere, this is another sort of connection. You're seeing just the two intersect in ways that are like actually, you're not able to totally disentangle them, which I think is one of the things that's so exciting, of course, about having this conference today and thinking about how do these two topics come together under the auspice of the groups who've convened us here. So I'm going to move on to part 2 on these global health innovations. This one, I'm not actually going to share this one, but it's some midwives in Ghana who are playing a game on the tablet that is around learning malaria treatment tactics. So it's a gamified version of health worker training, which is kind of cool. Okay, so I'm going to introduce you to 4 global health innovations, some of which I have more experience with than others, but I thought they were all kind of a nice set of examples. I'm going to start each time by sharing the challenge that the innovation sought to resolve. So this first challenge that the innovators faced, this group of innovators, so the challenge is that in India, there's over 500,000 children who die every year from vaccine-preventable disease. And rural child mortality is double what it is in urban areas. At the same time, rural healthcare workers, as hard as they try, lack reliable patient data to target the populations who most need their services. And medical records are often paper-based and held by families themselves. So a lot of times, just for context, because I certainly did not know this until I had joined the Peace Corps, that a lot of medical records look something like this. This is actually Kenya's current mother-child book, it's called. And instead of if you grew up in the States, you're probably familiar with either having an electronic medical record in the clinic that you went to, or even maybe a paper-based one, but it was left at the clinic and sort of the doctor and the team had access to it at all times. What actually happens in a lot of places around the world is that the patient is responsible for holding on to their own medical record and carrying it to the various health workers that they might visit, or facilities or clinics or hospitals. And so it's great, the book is great, there's tons of great information. In here it actually teaches the family, in this case the baby booklet, teaches the family about important growth milestones. But a lot of the information about that baby walks right out of the facility with the mom after that vaccination is given or the well child visit is completed, right? So you can imagine from a data perspective, like how does the clinic know how well they're doing when all of the data is walking out? And actually I'll pass this around just in case you guys are curious. This is the Kenya one. I'm talking about India now, but it's similar in a lot of parts of the world. So all right, let's do a little brainstorming. So you can conceptualize these challenges, maybe, right? Or try to at least. I'm going to share the innovation on the next slide, but what kind of innovation might this be? What characteristics might it have? And what's kind of the wild idea that comes to mind when you see this? Like, okay, what did they develop to resolve this issue? Any ideas? Even if it's not a full, you probably don't have the full image in your head, but what kind of things might it include if it were to address this?
Well, I hope they're duplicating the information in clinic.
Okay, you're hoping that there's some sort of information capture that the clinic gets to keep. Yep, okay. What other things might it have? Yeah?
More primary care in rural areas.
Oh, right, it might address primary care in rural areas, might be rural oriented. I love that, yep. Anything else?
Is it an app?
Is it an app? Does it have a digital component? Okay, great. Anything else pop to mind? Yeah.
Maybe like outreach or direct observed therapy kind of outreaching.
Okay, yep, that there's outreach, there's some kind of depth in the community. People are they're being visited and not having to centralize their visits. Yep, so they're all correct so far. So, all right, so, so this innovation, it's a wearable digital solution for tracking maternal and child health records that allows the health worker to digitally store and retrieve health records from the patient's wearable. So it's actually this pendant that the baby is wearing. It's called Cushy Baby. And it's so cool. This is like so cool to me. I cannot believe how cool this is. That little pendant allows the health worker to read and update the medical history, provide appropriate care, which is done, the reading is done through an app, and then all of that, it gets uploaded into a central place where the health clinic can, in fact, see the data as well. So they can go, okay, we know where we've got issues or we know where we've got gaps based on what data we're getting kind of back on the data dashboard. It's also less than $1. It's culturally appropriate, so the pendant, the shape, the look of it, the fact that it is a pendant worn around the neck has a lot of cultural relevance. They tested this a lot to arrive at that. In fact, I think they started with a wrist piece for the baby and ended here. It's also biometrically secure, so the caregiver has to give a thumbprint before even the app will pull up the medical record. So it's not just kind of, here's your medical information for anyone's access. It's still very secure. This is incredible, right? It's Cushy Baby. And they are now scaling up in Rajasthan in India. And so far they're in, how many million did I see? Multiple millions of users and expanding. And they actually now have a version of it for the mom as well, so they can track the mom's medical record. And actually, it did increase immunization by about 66% in their original control trial, and they're 5 times less likely to lose the pendant than that paper book that we were passing around, right? So it's helping resolve those problems that we saw on the first slide. Pretty cool, right? I love Cushy Baby. There's a lot of good case studies about this one, too. Okay, so now we're going to move on to the next challenge. If I could have favorites, this is probably my favorite one. The next challenge is that there are 200 million people who wish to prevent or time their next pregnancy, but who are not using a contraceptive to do so. And the use of contraception remains limited in a lot of parts of the world. So this is kind of characterizing what's happening in the space of contraceptive access, or what we often call birth control here in the US. And the WHO at the same time anticipates that there will be a health workforce shortage of about 15 million health workers by 2030. So we're already short of the number of health workers that we need. That is only going to get worse to keep up with the size of the population and to really increase coverage of health services. Okay, so what could a solution here include? What might it include? Characteristics, ideas, yeah.
Can I ask a question?
Sure, go for it, yeah.
Do these people would be open to would they be open to contraception, or is it that they don't want?
Sure, okay, good point. Yeah, let me clarify that because I think that's important to characterize. So this is technically 200 million characterized as a group of individuals who state a preference to either delay or not become pregnant in the next, I think, 2 years. Whether or not they want to use contraception is a little bit more nuanced, and I'm happy to talk about that. in a bit, but essentially this is saying, yes, I'm at risk of pregnancy, and no, I'm not using a contraceptive technology to prevent it. When we dig a little deeper, yeah, the number might be a little smaller who are saying, oh, I really, really want it and I can't access it, but it's probably still gonna be closer to the 200 million. So this is generally seen as an access issue or a sociocultural barrier to overcoming the stigma of using contraception. Yeah, go for it. Okay. Yes. Yeah, okay. So one possible solution is it might be a natural family planning method about, learning to use one of the traditional methods of family planning. Other ideas of what the solution could have been here? Yeah, Kelly, go for it.
Ways to lower the barriers to use
Okay.
cost, like instead of 1 pill a day, annual implant that you only have to deal with once a year.
Yeah. And there is an implant. It lasts 3 to 5 years, depending on which brand. But this one's not the implant, but that was good thinking. But it does reduce access barriers. Any other ideas of what kind of characteristics this innovation might have? Jeff, go for it.
200 million makes me think of my Walmart again, or maybe,
Oh, yeah.
business side of it rather than just relying on NGOs.
Yeah, okay, right. So it has to do with sort of the partnership and the model of delivery. Yeah.
Somebody might make a little money on it.
Yes, okay. And
store,
okay, which is good because that actually is part of this solution. So this one I'm also going to pass around with you. It's in my hand. That's how small it is. So the solution in this case is a contraceptive injection that is pre-filled into this single-use device. I will pass it around. This is the actual thing. And it's stable at room temperature, which allows people to keep them at home, like in a drawer, and self-inject when the time comes to do so. So those who are familiar with the range of contraceptives available in the US, you might be familiar with Depo-Provera, which is an injectable that's given in a traditional intramuscular syringe formulation once every 3 months. You go to the clinic, you get injected, you go back every 3 months. That is one of the most, actually is the most popular method of contraception in sub-Saharan Africa. Despite not being all that popular here in the US. So what it is this is a lower dose version of that same drug. And it's just in this package with a slightly shorter needle, which allows it to be administered subcutaneously right under the fat as opposed to intramuscular. And so it can then be administered by any trained person, including a health worker, a community health worker, a pharmacist, or the woman herself or her spouse or her friend, whomever. It's injected quarterly, just like the traditional formulation, and it's 99% effective. So let me pass this around. I did glue the cap on, just so we don't get any inadvertent needle sticks, because I'm sure that would not be good for the future of the Peace Studies Conference. But traditionally, there's a whole way that you pull the cap off, you activate it, you literally just shove it in your skin almost anywhere, stomach or thigh recommended, and then you squeeze this little bubble until the juice all comes out, and then you're done. So I'll pass that around. So it's called Cyanopress. That's its official name from Pfizer, but there's a couple generics underway. And it can be delivered in different models of care. So pharmacists or others who can kind of make money by selling it can actually do that as opposed to delivering in a traditional clinic setting. And this is a highly effective method. It's become very popular across parts of sub-Saharan Africa, which is super exciting. And people are able to use it discreetly because of its small size. Someone who's facing sort of stigma or maybe has, perhaps they're the victim of some gender-based violence and aren't really allowed to seek services in a facility could sort of come across this in a more discreet way and still control their own reproductive goals without those unfortunate circumstances. So this is Cyanopress. All right.
Question about that.
Yeah.
Is it, so for rural patients, quarterly use would still be difficult, I think. So it is
Yeah.
described like we can take
Yeah.
a full amount home.
Exactly.
Is it cost effective enough for lower income
Sure.
communities?
Yeah, great questions. Yeah, and I should have mentioned, you're right. So the value of it is that you could ostensibly take home 3 or 4 doses of these and not have to come back to the clinic every quarter, right? So the idea is you're going to the neighboring pharmacy or you're going to your health clinic and they're saying, oh yeah, you're eligible for this. Let me show you how to do it. let's do one now and take the other 3 home, you're protected for a year. So cost effectiveness, great question. Technically, the device is a little more expensive than a traditional intramuscular formulation. However, the cost effectiveness comes into play when you think about travel time, less time for health facilities to have to, do consultations with these women who are just coming just for the injection every 3 months. So the cost effectiveness is there. It's just if you have to look a little bit more broadly about the determinants that sort of create that cost effectiveness. It's not the product itself. Yeah.
What is the price per unit?
85 cents. Yeah.
Per dose?
Per dose, yep. It's more expensive than the intramuscular, I think, is about, I want to say 50 or 60 cents. So at the scale of a public health system in a country that has this available, like Uganda, where they've really taken this to scale, it really does add up. And if it's your most popular contraceptive, it's being used by millions in the population, you can see how those numbers would increase. But it's also incredibly valuable to have an option like this to those who want to use it. Yeah.
My question was a little bit, it's about this, but I just have a question. Depo shot is known for making women sterile.
Okay. So this is a good point. So there are a lot of, when it comes to contraceptives, there are a lot of perceptions that people have of them based on the experience of friends and family, and also I think the unfortunate sort of like rumors that end up kind of traveling through communities because of perhaps fear of contraception or a desire to stop individuals from using them. The method itself is actually incredibly safe and doesn't cause infertility. What sometimes gets mischaracterized about Depo-Provera, or in this case, the subcutaneous version, is that, I'll go over this briefly because I think it warrants maybe a different discussion, but it's very effective, and it can take a long time to sort of wean off of it at the end. It's called a contraceptive tail, meaning that some people who stop using it, they'll go, okay, at 3 months I can now get pregnant again because I just did my injection three months ago. Technically, the contraceptive tail means that it could be effective for maybe even 9 to 12 months beyond the time you injected it. This is it just kind of depends on your own personal biology. So some people sort of perceive that as infertility because they go, man, I stopped that thing 3 months ago and I can't get pregnant. When in reality, it's probably the contraceptive tail that's just particularly long on an individual. And of course, she might be frustrated about that, which is very warranted. And so says, oh, this thing may be infertile. But actually, it's incredibly safe, used by literally hundreds of millions of women around the world since 1976 when it was first invented. Okay, I'm going to move on to the next one. So here's the challenge. So in Rwanda, health facilities face major congestion due to their health worker shortages. They have about 1 primary care physician or general practitioner per 12,000 of the population. And sort of because of that, patients come to care sick, right? Because they're sort of avoiding having to go wait in a long line and know that they might even visit a facility and not be able to be seen that day. So they wait at home until the condition really worsens. And we saw a lot of this with COVID in the US, right? Like patients are now sicker than they were coming to the hospital a lot sicker than they were 3 years ago. At the same time, there is a challenge where any digital solution, like a telemedicine type solution, is often too small in scale, or maybe it's 12 months at a time to really make a big major impact. So what might be the solution here? What characteristics might it have? This one's a little more conceptual, so no product or device associated here. Any ideas? What might it do? What might a solution here do? Might it alleviate the burden on those health workers since there's so few of them? Perhaps, yeah? Okay. All right, so this one is a partnership. And the partnership is with the Rwandan government to provide what they're calling digital first primary care through an array of telemedicine offerings for anyone who's enrolled in Rwanda's national health insurance coverage. And Rwanda has their national health insurance coverage that enrolls, I believe, about 90% of the population. So this is a very, very substantial portion of Rwanda. So it's called Babel Rwanda, and I'll talk about why it's called that in a few slides for now. But it's called Babel Rwanda. This is an actual advertisement that they put out in Rwanda. And how it works is that individuals use their own phone or even a shared phone to access a kind of secure connection with either an AI, well, first an AI-powered triage, and then also for consultations with a health worker, to book lab services, to get electronic prescriptions, and so on. What's exciting about this is not only that it exists, but this is the largest single telemedicine platform in sub-Saharan Africa. And this 10-year partnership followed a kind of pilot phase. And so this 10-year partnership was signed in 2020. This is incredible. I mean, this is the scale of this telemedicine program in a low and middle income country is really sort of unseen. And they have, I think, 2.5 million Rwandans already enrolled of the 12 million of the population. So it's a pretty substantial proportion of Rwandans who are part of this. They've done like 3 million consultations. I think bigger results sort of remain to be seen and whether or not this can be sustained, but certainly everyone is watching this one quite closely. Okay. Our fourth and final challenge is this one. So there's 5 billion people around the world who lack access to quality, safe surgical care. And in-person surgical training or capacity building for surgeons is really intensive, right? It's costly, it takes time. You think about all of the training surgeons go through here in the US with their residencies and fellowships, and then even beyond that, they go through so much more training the rest of their careers. And surgical skill building is actually best provided when it can be done on demand, right? When you're in a case and you're going, oh gosh, something really went wrong here, having that mentor within the hospital that can come support you or you can talk through how to navigate a case with is a really important part of training as a surgeon. So this is the challenge. So what might the solution be here? What characteristics might it have? Any ideas? Yeah.
Some kind of communication network to like link more trained professionals with people who are just starting out.
Yeah, some type of communication network that links trained professionals with ones who are more early in their career. Yep. Did I have another hand over here? Yeah, Ellen.
I was just thinking of the example that doesn't go along with this, like Smile Train, where teams of Western
Yeah, I'm
go
glad you
around
mentioned that.
with this pallets that's like not building capacity, not available on demand.
Yeah.
So it's got to be something that like is
Right.
somehow building the human capital, like people doing rotations where they're training people in their
Yeah.
country with the tools that they have.
Yeah, I'm glad you mentioned that because actually the developer of this innovation was sort of inspired by her work doing cleft palate repair, going, this just does not seem like me flying from California to Peru is like a sustainable way to build surgical capacity, or it's maybe one tiny part of what could be a much bigger initiative. Okay, so this one actually, this is one of a couple of ones in which Jepaigo is pretty heavily involved. So the solution is an augmented reality remote capacity building platform that connects surgeons with preceptors around the globe. So you hit the nail on the head over there. That was perfect. It's called Proximi AR. And the way that it works is it's a technology that layers in these digitally created content. So it has like medical imaging, it has this AR hand, which I'll talk about, and allows the mentors to kind of virtually scrub in, is the way they put it, from anywhere in the world. So if you can imagine sort of an operating room that in this case in a low and middle income country. So for example, we're doing this in Kenya insofar as it relates to safe cesarean sections. And in the operating room, you do have to put in a little bit of capital investment to equip it with, I think, 3 to 4 cameras. There's one directly looking at the surgical site, one that looks at the room as a whole, one that kind of faces the primary surgeon so that they can have a conversation. But the mentor can be even on their phone and go as they're being called in and going, okay, yeah, let me see, can I see how is the team in the room like currently configured? Okay, let's bring your scrub nurse to the left side of you, it'll give you a better angle. And they can use this cool AR hand, which right here they're doing on an anatomical model for a cesarean section. And didn't think a full cesarean section photo was going to be an appropriate fit for today. And you can see that the mentor, what they have is a camera at their disposal that allows them to move their hand around and actually point at things to indicate what needs to change or what needs to be corrected or where a certain procedure needs to be done. And so this is probably the newest of the innovations that I shared today, but it's just super exciting to see things like this happening and really connecting these longer form partnerships, right, that enable health equity. So just to touch a little bit on the origin stories of these, because I think it's helpful to think about where did these come from. I'll let you reflect on this a little bit as well. But so Cushy Baby originated in 2014 as an undergraduate project of the founder. He's still founder. Well, he was at Yale. Ciena Press, the injectable, is actually, the products are old. So the Uniject device that it's packaged in was developed in 1987, and the drug that's in it was developed in 1976. But it wasn't until 2014 that they got put together, and that partnership was negotiated amongst donors and development partners and the pharmaceutical companies and the owner of the patent on the device to say, hey, let's see if we can deliver contraceptives in this thing, and then, commit to making millions of them over the next 10 years so that we can get them all around the world. Babel, Rwanda, is actually the kind of daughter of a UK-based company that is a big part of the National Health Service in the UK. So what they're offering in Rwanda is what they also offer in the UK. And they started this partnership in 2016 in Rwanda, and then, like I said, they launched their 10-year partnership in 2020. So this is the first place of many where they hope to make Babel a telemedicine platform for the masses. And then, Proximie AR started when a California-based plastic surgeon who'd been doing cleft lip repairs around the world said, there's got to be a better way for me to provide support to these surgeons when I go back home. And so she built Proximie, which is just really incredible, right? I will note, as you've probably noted, this is maybe not the most impressive array of sources of innovations, right? These are largely innovators that started in the US and UK, which is part of the problem. Okay, so we're going to talk then about the changing landscape for innovations and equity, and sort of reflect a little bit on why is it that so many innovations are coming from high-income countries. So we're here together today under this theme of partnership equity, right? And one of the incredible things about innovation is that innovation exists only in partnership. Innovation is sort of impossible to do alone. It requires a lot of partnership. And here are three kind of characterizations of the type of partnerships that are required to innovate. So there's the relationship between the innovator and the funder. Who's paying for this? Who's giving the funds? Who's resourcing it, right? There's also a relationship between the innovator and the implementer. So this could be, like with Babel, it could be Babel and the Rwandan government. So saying, hey, we've got the tech, you've got the primary care platform in which we can integrate this. Or it could be a fellow kind of innovator who has an asset that you need. Maybe they have intellectual property or a part of a device, and there's a partnership there. And then there's also, of course, the partnership between the innovator and the end user, the intended user of the innovation. And we're going to dive into a couple of these just to talk about how global health is changing and what this means potentially for partnership equity. Okay, so as we start to think about the relationship or the partnership between funder and innovator, by nature, the donor or funder relationships are full of disproportionate power, right? When you're giving money, you're already sort of setting a stage for a relationship which probably it's not gonna have equity at its foundation. And so you have to, if you want to correct that, you really need to work hard to do so. And I think there are some exciting ways how this is happening in global health. And one of them has to do with the Global Grand Challenges. So Global Grand Challenges is, I think, probably the largest funder of global health innovations. It's a subset of funds that certain donors pay into, like the US government, Bill and Melinda Gates Foundation, and others. And essentially, since 2003, they've been launching what they call Global Health Challenges. And then innovators can apply for funding to say, oh, we think we have a solution for that. So one of the famous challenges that Bill Gates always talks about them launching was about, creating a better toilet, right? So they'll say, hey, we need a better toilet. We're taking all ideas, right? And we'll start with phase 1 funding is $100,000. If you hit some benchmarks, we might be able to give you more. You can reapply and get more money. Well, great idea, and certainly it has really grown and shaped. But when it started in 2003, they noticed, oh, we're pretty much only getting and giving money to innovators from high-income countries, which is a little problematic given that these solutions are meant for low and middle-income countries, and that seems to be a little misaligned and probably isn't yielding us the best solutions. So they did some rectification of the process. They changed the application. They made it a lot shorter. They blinded the reviewers, and lo and behold, they had a much more diverse set of fundees by 2008, right? And then in 2012, so about 10 years after they launched the initiative, they actually started building out, I think now 17 different versions of the Global Grand Challenges led by local institutions. So now there's Grand Challenges China, Grand Challenges India, Grand Challenges Africa. There's all these different kind of versions of it that are actually not only funded in these kind of dispersed scenarios, but also you can imagine the decision-making about who gets money is then also dispersed and likely leads to a lot more diverse funding. And indeed it does. Oh, to date, they've given over $500 million to innovators in 86 countries, I believe. So it's really an evolving model of how global health innovation is being funded. But there's not only donor funding or sort of traditional development space funding going into innovations. There's also, of course, some like market-based models. So I thought this was kind of a cool example of another way in which funding for global health innovation is changing. So Vilgrow is an Indian-based social enterprise incubator. And so what they do is they seek out cool innovations. They started by doing this just in India on certain subtopics, and then they provide some sort of like mentorship or incubation accelerator support in return for what would hopefully be a share of the revenue of that company if the venture proves successful. And they're doing work in agriculture, in health and education, et cetera. So they started in India, made their first impact investment in 2001. By 2014, they had funded over 100 startups, and by now it's over 300 something that they have incubated in Vilgrow. And in 2019, they did this really incredible thing, and they said, well, let's build more Vilgrow type institutions around the world. And so they launched what's called the Incubating Incubators program in 7 global markets. So there's now Vilgrow Kenya, and there's Vilgrow in other places, and then they're also incubating other versions that aren't even Vilgrow. And so this is a great idea, sort of market-oriented, thinking about solutions not only coming from this sort of donor-funded space, but also how can you use private equity and capital to foster innovation and grow it for revenue, right? The other partnership I thought was important to dwell on today is the one between the innovator and the end user. So that was the innovator and funder on the last one. So when it comes to the innovator and the end user, one of the exciting things happening in global health is this embracing of what's called design thinking, human-centered design. It's like user-centered design, which essentially is just a way of talking about problem solving with a special set of skills, mindset, and tools that embrace co-design. So how do we bring the end users to the table with us to better understand what the problem is that we're trying to solve and what potential solutions might be fitting for this, and then actually helping kind of co-build prototypes and test those and see if they work. And this is super exciting because at its core, by being a co-design approach, this design thinking approach, you're really starting with partnership. You're saying, okay, we as maybe the biomedical engineer or the person with the MPH has sort of a population level understanding of what's going on, but I don't actually fully understand what's driving this challenge. So this is a really exciting way in which partnership is coming into innovation as well. And just to give you an example, based on that product, the Cyanopress that we were passing around, that contraceptive. So for example, some colleagues of ours at Population Services International, which is one of our kind of partners. They do incredible work around the world. They were working on that self-injectable in Nigeria and Uganda. And in Uganda in particular, this is the most popular, injectable contraception is the most popular method of birth control in the entire country, has been for decades. So they thought, okay, we've got high interest in injectables. People already love the product. And they're saying, oh yeah, we would love to have it in a self-injectable format where I can take it home and I don't have to come back to the clinic for a year, right? This is high convenience. So what happened was that they started, training women that already used the intramuscular version on how to self-inject, but only about half of them were actually, after the training, going, yeah, give me 3 units. I want to take it home and do it myself. About half of them were saying, I don't know, why don't you keep injecting me, nurse or doctor, whoever, right? And so they said, let's employ some design thinking. Let's really come to the table with a deeper understanding, come around the table to achieve a deeper understanding and some solutions that would help women feel more confident to do this self-injection because they want it, they're talking about it, they have high aspirations, and yet it's not happening. So they found out that it was the fear of the needle that women were really concerned about, and maybe it wasn't even the needle itself, it was this idea that they hadn't ever taken it upon themselves to do sort of self-manage their health, to treat themselves. And so it was a little bit of a fear of needle, but it was also just a lack of confidence over taking control of one's health overall, right? So they said, okay, how can we help you feel better about doing this? And so they brought women to the table, they brought midwives, they brought OBGYNs and everyone, and they came to, through all these design processes, that they needed an empathy-driven training approach. They said, we need to, first and foremost, surface the fears. What is she scared of? And then, because the fears are pretty consistent, let's have 5 key messages ready to go for healthcare providers so that when she says, that needle, I don't think can I do it? I'm not trained as a health worker. I didn't go to nursing school. That the health worker knows exactly what they can say, which is accurate and reassuring because they've tested this messaging in populations before. So they kind of prototyped, they tested these things, and they ended up creating this incredible training package on building empathy among healthcare providers to kind of treat those fears as really valid and something that they needed to kind of improve their fluency as healthcare providers to navigate. One of the cool findings of this is not only did they then get higher conversion to self-injection among those who wanted to use the product, but they also found that healthcare workers reported that their clinical encounters for other health issues were also far more empathetic than they had ever been. They said, oh my gosh, I am asking questions that I never thought to ask before, because they've been thinking about empathy and sort of their clients' fears in ways that they had never done. All right, I think I'm going to skip this one, but just to mention, there's a lot of ways this sort of design thinking can be used in global health, and McKinsey did a great report on this a couple years ago. I spoke about a project-based application, but there's also much broader ways that can come into play. Okay, so those are a couple of ways that partnership comes into innovation, and I think the ways in which it's evolving towards solutions where equity can play a bigger role, but I think the reality is that none of this is enough to kind of create true equity or partnership equity in global health innovations. And there's this quote from a paper that Professor Abimbola, who's the chief editor of the British Medical Journal of Global Health, wrote this year, and it reads, "Reimagining global health in the post-COVID-19 world requires that we address the intersecting systems of supremacy that continue to limit our ability to achieve equity and justice. Inequities are not only about the needs and concerns of the disadvantaged, but also the systems that create disadvantages," right? So all of this, these are all on the pathway to something good, but certainly not even nearly enough to create true equity or to speak about how we change the systems that disadvantage parts of our population in the first place. So I will leave you with this sentiment before we kind of move into some discussion and Q&A. But a colleague of mine recently introduced me to this concept of adjacent possibles. Has anyone heard of this? I was like, you've heard about adjacent possibles. Okay. I love it, right? So adjacent possibles is this concept that comes from evolutionary biology. This makes sense, right? Because in biology, we know that things can only evolve to the next adjacent possibility. You can't evolve a creature from one thing to what it's going to be in 10,000 years from now without all these little kind of increments along the way. So the kind of a definition here is that in any system that's evolving over time, whether it is biological, like that evolutionary biology perspective, or a cultural one, there's only a finite set of ways that the system can be changed, and then a much larger set of changes that can't yet be made. So if you think about this graphic, there are your adjacent possibles, which are those first nodes out of the central, and then there's the next things, right? These things that you're working towards. And so in that way, the adjacent possible is what hovers on the edges of the present state of things, like a map of all the ways in which the present can reinvent itself. So two things. First of all, this is not to dismiss radical action. As a peace studies major, I would never aim to do that. It's actually instead to sort of suggest that if you're envisioning radical change in anything, whether it's partnership equity in global health, in peace, in any cause, perhaps our sights are set on some of the goals that are a little further out there, but we need to achieve them through our adjacent possibles, and that you can actually imagine the world, this is what I'll ask you to do, is to sort of imagine imagine the world that you envision, whether that's one of global health equity, as many of you I think it is, or if it's something else, and to think about, well, what's the next adjacent possible, and how do we reshape our present to move closer and closer on that pathway to create that vision that we have in our minds. So I thought this was a cool concept. I keep thinking about it. But with that, I'm going to leave you with a few of these resources. I'll leave this up. The link for my presentation is right here. I felt really cool putting a QR code up there. So I've never actually done that weirdly. I don't know. I feel like I'm 37, but maybe 67. So this is the link for this. There's a couple great resources here. There's the Global Healthy Learning courses if you want to dig into like 2-hour coursework on a variety, probably hundreds of different global health topics. The Global Health Now newsletter. So this is run by Johns Hopkins. So just disclaimer since I work for them, but this is a really, really great newsletter, daily newsletter for your inbox. And then when I was talking about design for health, there's actually an entire website managed by the Gates Foundation and USAID, the US Agency for International Development, where you can read more about how that's being used. There's also some links on the slides, but if you wanted more information about something and didn't see me link it, you can always reach out as well. Okay, so we have about, I think, just under 15 minutes. So for now, I kind of want to move it into discussion, Q&A. What types of sort of questions, comments, ideas do you have about global health equity and partnership equity, questions that you have or sort of topics that you're mulling over? And I will note for this in particular, there are mics on both sides of the room. So if you could use those, I think we have some students who are going to pass them around, or you could walk up to them or move to them. That would be great. And feel free to introduce yourself as you do this so I know who you are and what you're studying, et cetera. Questions, comments, et cetera. Anything that surprised you?
Just go ahead and raise your hand
Yeah.
and we'll bring a mic to you.
I forget, very classroom oriented. Oh, Ellen, go for it, yeah.
Well, the students are thinking.
Yes, while they're thinking. While they're thinking.
Okay, great. Thank you so much. That was really, really captivating. I'm thinking about like what's something that was in common of a lot of the examples you gave was kind of trusting people to be able to do things. Like I'm thinking about the story that people told about antiretroviral drugs for HIV was like, well, can we really trust Southern Africans to take them properly? You have to take them at the same time every day and every night. And like, actually it turns out that they take them as badly as we do. Everybody's bad at taking their meds on time, basically. But like a lot of the things you were, telehealth, that takes a certain amount of trust and self-reporting or injecting yourself properly or whatever. But then also I'm thinking about like the technological side of the solutions and this adjacent idea. It reminds me of like over-innovation is one of the things that often people do when they go to a new country and are like, ooh, I have a solution for your problem. And then it's like, try this, and it doesn't work for all these reasons that you don't understand the cultural context. There's not the support for the technology. And there's all these examples of global health of like, the cameras stop working in the surgical thing, and then this whole system you've built up. Like we had in rural Lesotho, where I work, we had a CD4 machine, which is like the way to tell how sick somebody is if they have HIV. It was broken for like half a year. They couldn't even take CD4 samples. They just had to assess people's severity of their AIDS based on their symptoms. And like that's a pretty basic machine that's all over sub-Saharan Africa. So I'm just wondering if like, what are even the necklace, like the thumbprint thing stops working, and then is there someone in country who can repair it, or the parts to repair it, and then it's like months and months that's broken. There's a lot in what I just said. I apologize for the stream of consciousness, but
yeah, no, I hear you, and I think that's a great point. I think, when you study global health or global development, there's this terminology, and I'm sure you're familiar, but for others, this idea of appropriate technology, right? So not thinking about what is the single best way or most innovative solution for the problem, but how do you sort of filter the solutions through what is possible for solving the problem and what is appropriate, right? Like what is appropriate because of cultural context or because of insufficient power reliability, right? That we know they're going to be on and off grid constantly. You don't want a solution that relies exclusively on power. And so appropriate technology is an important part of global health or global development studies. And I think in these cases, so like Cushy Baby, they did a ton of testing. So the team at Yale who developed this, they then like moved to Rajasthan for 2 months and like just did intensive work understanding the community, understanding what would be acceptable. The device actually works offline, the pendant does, so you can still scan it and retrieve the records from the app without having a connection, which is great. And then it just uploads once you're in, Wi-Fi or 3G or whatever they have. So there's a lot of consideration that comes into developing the innovation in a way that is contextually useful. And I think even in the case of Proximie, like the work we're doing to test that in ORs in Makueni County in Kenya to do this cesarean section mentorship, again, it was like, how do you choose a site where this is reliably something that they can connect to? And an OR that doesn't have power isn't going to be doing surgery. For that OR, it's not. So it's kind of like, all right, this is a place where they've got the lighting, we can hook up, they've got a stable internet connection, they've got generators to back their electricity for when it comes off or goes off. So, there's a lot of filters, and I think some of the approaches that are being used, like Grand Challenges, saying we should be funding innovators from these communities who know what is appropriate because innately that's what, they're from these communities. They obviously wouldn't invent something that isn't appropriate or wouldn't work. Or this approach to design, which might be led by an outsider, but kind of captures the perspective of the end user in more insightful and deep ways, I think is also really, really promising. We're seeing innovations become a lot more applicable to the communities that are being targeted with them, which is great. It's not the full answer, but it's kind of closer on the pathway than saying, hey, we developed something in a lab here in Minnesota, see if it works, right? Yeah, so it's a great point about that. Other questions, thoughts, ideas? Concepts you're noodling over. Oh, all the way in the back. We got to get you a mic. Sorry, because it's being recorded, so. Sorry, I'm just make you hustle.
Do you have to counter misinformation in educating people? I'm thinking of people I've heard here stateside talk about how Bill and Melinda Gates want to poison all of us with the money that they've given to ensure that these global trends happen. So is that a major part of the work that you're doing throughout the world?
Whew. So misinformation and knowledge are a really interesting topic, right? Because at the end of the day, when someone has what we might call a myth or a misconception or misinformation, we could also just as easily call their own local knowledge, right? So it's sort of thinking about it in a couple ways. First of all, recognizing that what someone believes is true, they believe for a reason, right? There's a belief system, there's a chain of messaging that got to them that sort of fits a mental model that they have. And so instead of sort of saying, let me correct you on that, it's really trying to understand, where does that come from? Where does this fear come from? And of course, the vaccines that the Gates Foundation is funding are incredibly, incredibly safe, but I can also appreciate why a community who has been victim of colonialization and all of these terrible systems might have skepticism about something coming at them from another high-income donor or high-income community, right? And so in a case like that, it is very challenging to consider, how do we address the gap in understanding of what this is in order to achieve a better public health outcome, right? Not to say you're wrong and we're right, but to say, okay, at the end of the day, we want you safe, healthy, and thriving. And this sort of perception of, in that case, the vaccine is inhibiting our ability to do that. That's a really tricky topic. And I think we're seeing it play out right now, and there's clearly no single solution. Part of it is sort of owning up to saying, actually, I understand why you're skeptical. Let me walk through what I know and answer your questions that might be kind of, maybe we can reach a common understanding here. That misinformation is such a huge and important topic in public health. Health literacy and all of that. Other questions, comments? We got 5 minutes. Let's get you a mic here. Student will run it over for you.
I'm just wondering, what are the largest institutional barriers that you run into I'm just thinking things like, insurance, government, all those kind of things. So people probably come up with some really good solutions, but they have trouble getting them instituted because of all these systems that are in place and getting them to all work together. Yeah, all of the things you named are challenges, right? So any global health innovation
most global health innovations fail just terribly. In fact, that global grand challenges, I was just reading an article when I was preparing for this, that they believe that not one of the global grand challenges has actually truly taken off and revolutionized the world yet, despite being a 19-year-old program funding innovations and $500 million of investment. Many have made measurable progress, but none have sort of achieved this, like, we solved the challenge that we were setting out to solve. And Bill Gates himself, who is one of the major funders of that, says, oh, that's what I expected. I didn't expect us to have any like silver bullets in here. But we know that by unlocking innovation in certain areas, we will make progress, but we'll also discover things that help us in other areas. And if we kind of share evidence with one another, then hopefully we're making the world better and improving global health for everyone. So first, just to say, none of them have really taken off. None of those ones have taken off in a big way. But institutional barrier, I mean, there's just so many. I think one of them has to do with the length of funding cycles. So in the development space in global health, you're prone to do things on the time horizon in which your donor funds you for that work, right? So a lot of US government grants last about 5 years. Foundations are usually shorter. So you can only reach progress for that amount of time before you know your money's running out, and you may or may not get more funding. And that's true whether you're a nonprofit organization like we are, or you're getting direct funding from as a government or a local institution. And so I think the funding cycles are an issue. I think, also just health systems are incredibly complex. I mean, the US is certainly an example of that. We have an incredibly complex system. That's why you don't see big national solutions to our health problems, partially because we have a diverse country, but also because it is just too tangled to be able to sort of say, this will work everywhere, right? And so, that level of complexity exists elsewhere as well. And so, you just have to like keep working, try and make progress and document it along the way. I think these 4 are really promising. I think these are 4 that have actually reached some pretty cool benchmarks or are looking like they will. The Babel partnership, I know it's a little conceptual, but that 10-year partnership is like just mind-blowing. Because telemedicine is never offered at that scale. So being able to see that is great, very promising. Any final questions or thoughts? Otherwise, Jeff is gonna say something here.
I'm actually going to ask a question for those who is as fascinating as this global health space is, and you can see you could do it with any major or minor. So the comm people, you should be seeing like, wow, that could be great space for me. But for those who don't end up going into global health, you still have a lifetime, however long we're going to live. I know life expectancy is dropping, but you still got decades of the ask. Organizations are going to be asking you to give, to help. And so I want my 38 cents a day, to be able to do something. How do you evaluate organizations in this space? And then kind of a related one, if I were to say, I want it to be cost effective too, do you wince when you hear that, or what are the pros and the cons of cost effective? I know Paul Farmer thought that, the focus on cost effectiveness kind of ended up breaking our moral compass kind of thing, led us to turn away from things that we shouldn't have. So just how do you evaluate organizations that are going to be asking us for the next several decades, and then how do you, that animal of cost effectiveness?
So evaluating organizations, I think, you can always ask someone who works in that field or domain, whether it's something local to Minnesota or the US or international, hey, what do you think of this organization? We'll generally have a pretty good meter on how they're oriented and how they spend their funds. You can also go to their website, read a little bit more about who they are. I personally, when donating, love to look at how their leadership team is comprised and whether or not it includes people from the communities that they intend to serve, and hopefully is led by someone from those communities or their board, so you can kind of see if they represent your values. And then there are more traditional things. You can go to GuideStar or these other like Charity Navigator type websites that actually look at tax statements of all of these nonprofits and sort of evaluate how much money are they taking for overhead, how much money is going direct to their work, do they have any kind of issues in their audits, et cetera, et cetera. So you want to look at high-rated institutions to give money to, and certainly there are plenty. And if you have topics and you're curious who does it, so you can contribute or learn more about them, feel free. I can try and direct you to the pertinent ones. Cost effectiveness, I think I agree with Paul Farmer that cost effectiveness is rarely giving us the best, or rarely when we drive our work with cost effectiveness are we going to be kind of fully encompassing what it means to support someone to thrive, right? Because cost effectiveness calculations and measures are insufficient in capturing all of the benefits that a certain intervention can bring. But they are important, and I actually have had to be reminded by my own colleagues that when you're working with like a government, for example, we have a government where we're trying to introduce this self-injective contraceptive, and they are just like, it's got to be cost effective. It has to be cost effective. It has to be cost effective. And they're just driving us on this, like, make sure your cost effectiveness study is just perfect. And I'm like, come on, isn't it enough that it's like delivering health access to people who haven't had access before? But it's not enough to them. And as a government, if I put myself in their shoes, I have to recognize that at the end of the day, they have a budget in front of them, and they need to know which products to procure with the limited funds that they have. And they do want to know that this is a good investment. And in the reality, you know, that's what a lot of government officials face. And so cost effectiveness as a government's like meter of whether or not to invest in something is actually really critical. And so as a good partner, it's saying, all right, we'll build you a good cost effectiveness study then, because that's what's going to enable you to do your leadership best that you can. So, and make those difficult decisions. So I think that's one way to look at it too. Anyway, yeah. Thanks, guys.